Very quick primer on collaboratives. A collaborative is a network of people who share information, build on existing knowledge, develop expertise and solve problems for a common purpose, driven by the interest of the community involved. Now, in this case, the community involved was the local DHB project teams. The local DHB project teams undertook pathway mapping from the perspective of a person presenting at emergency department with deliberate self-harm or suicidal ideation, and following their pathway through the hospital system, through to emergency department, mental health services, Māori health and or Māori mental health, and through discharge and follow-up. And through that process identified gaps, barriers and opportunities for making process improvements to improve the consumer's journey through that system. Our objectives in conducting the evaluation were to review the quality of project implementation at a national level. So we were implementing the collaborative as a whole as a method of guideline implementation and not looking at the performance of the individual DHBs. It was principally a qualitative evaluation. What we've done here is outline the key actors involved in the collaborative, so the who, the what, and along the bottom the how, and then the key outcomes that were anticipated or that were intended. Now this is at a very high level, and within each of those boxes we then focused on success factors, quality of implementation, what impacts were achieved. The key actors or groups involved: the New Zealand Guidelines Group National Implementation Team, whose job it was to support local project teams within each of the participating DHBs. Then the DHB project teams, which needed to first learn the breakthrough methods and the collaborative methodology and then apply that methodology. And those circular yellow arrows there just denote the fact that the methodology involves an iterative process of trialling small changes and then measuring their impacts, and where those show promise, implementing them more widely. DHB management had a really important role to play as well in terms of providing resources. Just a quick snapshot of the how: the importance of cultural responsiveness, particularly bearing in mind the disproportionate impact of suicide in Māori and Pacific communities. The theme of whakawhanaungatanga, which in this context spoke to the definition used, was commitment from the different services to work together with respect, aroha, and share responsibility for one another. The intended outcomes, the immediate outcomes, were practice improvements: improved mental health, reduced significant self-harm and reduced suicide. Now, I mentioned before that the methodology involved an iterative cyclical process, and here's just a quick snapshot of that. The teams planned a small change to be trialled. They conducted then a trial of that proposed change. They studied the impacts of the trial, and then where that showed that it had been effective, they took it up a scale and did it larger scale across the departments. And then they went around again with another incremental improvement, and so that was an ongoing cycle throughout.
90% of people that present with risk of self-harm and suicide would be seen by a trained clinician and have a comprehensive mental health assessment carried out within 72 hours. What happened in the DHBs was that they developed and or improved pre-existing assessment tools and templates to suit their local contexts. This included, for example, a template that the New Zealand Guidelines Group developed. These assessment tools were then trialled to see how well they actually worked in practice. And once they had proven that they were valuable, they were implemented. Staff were then trained around using those templates. They were also trained around initial assessment in general, and also about how to sort of respond to self-harm and suicide presentations. I think what the biggest thing that came out of this was that there was improved knowledge and awareness about self-harm and suicide amongst ED staff as well. There were increased skills and confidence to ask the relevant questions of people at risk, and as a result of that, mental health issues were being detected and acted on more promptly. In the words of one ED nurse manager, there is increased confidence of ED staff because of training and the tools. People used to be left just sitting there. There were no key processes. Nurses felt uncomfortable and didn't know how to talk about self-harm and suicide. Most ED staff had the confidence to deal with this client group now, which they didn't have before. The second target area was assessment. The aim here was that all people that present with risk of self-harm and suicide get a comprehensive mental health assessment carried out by a trained clinician And what happened in the DHBs was that there were processes put in place for mental health services to be alerted and engaged with more promptly. And there were communication channels between emergency departments and mental health services developed. And as a result of this, there were also processes put in place to ascertain urgency in some presentations, then also potentially having assessments taking place out of hours. There were processes put in place for mental health assessments to take place prior to medical clearance as well, which in the past had been a reason for long waiting times. There were mental health staff increased their presence in emergency departments as well. And there were improved electronic records introduced, meaning that files were shared between mental health and emergency departments, and that both departments had their notes on those same files, so there was a better understanding about what was happening in the different departments in that sense. The impacts of making those changes then were improved communication and relationships between ED and mental health. And like one service manager of mental health and addiction services said, the relationship between ED and mental health is more open. ED can now say to mental health that they need to get to ED to do assessment quicker. The second sub-target of the assessment focus was the cultural assessment. The aim here was that all Māori who present with self-harm and suicide are offered a cultural assessment within 72 hours. What happened in the DHBs was that there were collaboration between departments to develop strategies for improving their cultural responsiveness overall. There were more proactive efforts to offer Māori patients cultural input. Cultural specific questions included in the initial assessment forms. Questions, for example, if the patient would like whānau support. Many DHBs also made available appropriate space in ED to carry out cultural assessment. This had been an issue before, that there hadn't been a private or quiet enough area to actually carry this out. There were improved collaboration between Māori Health and other departments. Also connections being made with Māori providers in the community. So overall, these relationships were strengthened. In one DHB, for example, the Māori mental health team had invited Kamatua to be part of these discussions, and they were talking about how ED could operate from a marae-based model. So overall, there was a much stronger cultural lens in emergency departments. The third target area that they were working towards was discharge. All people who presented with self-harm and suicide at discharge would be provided with discharge plans, both to patients and to the family whānau as well. And what happened within the DHBs was that discharge forms were being developed and implemented. And in developing these discharge forms, there were an emphasis put on using a language that patients and the family could actually understand, so using layperson's language. There were also resources developed for families to take home, such as booklets with information about what types of support they could access as they move forward. The impacts of making these changes then, obviously more people received discharge plans when they were discharged, as well as more family and whānau receiving those discharge plans. They contain more useful and clear information, useful in the sense that there were information about what would happen within the next 48 hours, who would be contacting them, those sort of things, where they could get further support if needed. And as a result, also then better engagement with the primary care sector. The last and fourth target area was follow-up. Everyone would have a follow-up appointment post-discharge within 48 hours. And the second part of this target was that any of those follow-up appointments that weren't attended would also be followed up on by the appropriate care provider. And what the DHBs did was that they implemented processes for automatically referring people at risk of suicide, self-harm to mental health services. Going across all those targets then was improving the infrastructure so that patient notes could be accessed by both mental health and ED. There were processes developed for people to be referred to mental health to be contacted by that service prior to their follow-up as a reminder that it was taking place. In some DHBs it was written in policy that all current mental health unit clients be seen by that service after discharge from ED. And there were also processes put in place to improve communication between DHBs and services in the community. The impacts of this was then that there was improved referral processes and continuity of care, improved follow-up of DNAs in the 4 DHBs that actually implemented changes in this specific area. Another ED nurse manager said follow-up is better. Before, ED usually had no idea what happened once patient went to mental health, and now all information can be found in the notes.
Part of the model involves having a national implementation team. So in this case, obviously, that was the New Zealand Guidelines Group. That team needs to have the credibility to engage with clinicians and managers in the relevant departments. It needs to bring a useful mix of skills and disciplines, and in fact the team mix at national level needs to mirror the team mix that's expected within the DHB project teams. The leadership style needs to facilitate and model the values of the collaborative methodology, and the team needs to be able to generate excitement for the project. And of course the national team needs to provide effective national support. What does that support look like? It involves an initial induction training workshop to provide the foundation for those DHB project teams to begin learning and working with the collaborative methodology. It then involves ongoing regular teleconferences, meetings and workshops, and the multiple methods there are important so that there are different opportunities to engage throughout, providing information and motivation and support. And that all needs to be provided in a way, of course, that the stakeholders themselves in the DHB teams find relevant and useful, and that they find that accessible. And so in order to be accessible, there's an on-call component to this as well. It's that being available in an ad hoc way to be able to pick up the phone and answer questions. And if necessary, to be able to fly out and have a meeting and resolve an issue as it arises. There's a really important role too for local executive support within the DHBs, and that was something that was recognised from work that had already been done overseas and was picked up on by the Guidelines Group, and the senior management of the DHBs had to express initial interest in being part of the collaborative through an expression of interest or EOI process. And as part of that, they were signing up to the core requirements of the project, nominating appropriate project coordinator, clinical leads from emergency department and mental health, acknowledging and pledging dedicated staff release time at the very least for the project coordinator and other resources to help make that collaborative happen. And it was important for executive sponsors to understand and champion the project at senior management level so that that was understood and remained on the table at DHB level. Now, the local project teams, success factors for those teams involved having representation from all departments, really important. Emergency department, mental health, and in many or most cases Māori health and or Māori mental health. And that involved having consumer and family and whānau advisors involved there too, particularly given the importance of the pathway mapping component and identifying what the issues and gaps are from a consumer's perspective, not the perspective of clinicians. Whole team ownership and commitment to change, the importance of that can't be overstated, and was the genesis, in my mind, of the whakawhanaungatanga theme that underpinned the whole collaborative. And it was important for the teams to have effective mechanisms for communication within the team and progressing the project while recognising that they had significant logistical challenges. The local project teams needed to learn the methodology, and that success factors for that includes initial team building prior to that first induction workshop. In many cases, this project team in the early days was being brought together with people from different professional groups, different departments who didn't know each other well, possibly didn't know each other at all, and some process of developing team cohesion needed to happen at the start. And really where the project teams took off most successfully, that team building had happened before they came along to the induction workshop, so that when they sat down they were ready to start learning the collaborative methodology rather than being diverted into the process of getting to know one another. And there's a lot of new information to absorb initially, so the workshop needs to provide enough of a base to get started, both in terms of becoming familiar with the methodology, familiar enough to be able to take the methodology home and just start working with it, familiarity with the underpinning values, in particular whakawhanaungatanga is a good example, and understanding how, where and from whom to access support and expertise from the National Guidelines Group team when needed. Success factors around applying the methodology, well, the pathway mapping is central to that. It needs to be a consumer-centred approach, and again that can't be overstated. That's a very important part of this project. And there are ground rules which are part of the breakthrough methodology, part of pathway mapping, which involves respecting diversity within the group and differences of opinion. The group needed to learn and follow the breakthrough methods, and a very quick snapshot there involves defining the problem, setting clear and agreed aims, goals and measures, and testing changes and monitoring improvements prior to implementation. The Institute for Healthcare Improvement in the US has some excellent resources online that talk about the breakthrough method. The Guidelines Group implementation team, if you've got any questions, want to learn more about the collaborative methodology itself, that would be your first port of call. Our report, I understand, is becoming available today on Te Pou's website, and websites for myself and Michelle are provided there as well. So thank you very much for listening, and we're happy to take questions at this time.